Oh, a 80-year-old man comes to office for routine follow-up. He has been hospitalized 4 times during the past year for management of congestive heart failure. It follows a 2 gram per day sodium restricted diet. Blood pressure is high, other vital signs normal. Lungs are clear, cardiac exam is fine. Serum studies show potassium of 3.8, which is normal. Total cholesterol is 260, which is high, and tag is 300, which is high. These findings have been consistent during the past year. Which of the following is most likely to decrease this patient risk for future hospitalization?
Is old patient mm, hospitalized for time?
Ready?
Yes. Okay. uh, the general the general management of chronic congestive heart failure. The general management of chronic congestive heart failure involves treatment of the underlying cause such as ischemic heart disease, valvular disease, reversible causes of the cardiomyopathy, control of associated conditions such as hypertension, diabetes, thyroid function, hyperlipidemia, and alleviation of the symptom. For this patient, improving control of the blood pressure is most likely to decrease the risk for future hospitalization. Hypertension is an important modifiable risk factor in this patient with heart failure. Increase of Hypertension is an important modifiable risk factor in this patient with heart failure. Increase after load puts an additional strain on the left ventricle, leading to further cardiomyocyte structural remodeling and progression of the left ventricular failure. Maintaining of lower blood pressure improves cardiac output along with the symptoms of heart failure and slows the rate of the ventricular decline. Okay.
47 woman comes to physician because 4-month history of intermittent substernal chest pain with exertion. She describes the pain as pressure-like and says it's relieved with rest. Does not have shortness of breath or nausea or sweating during the process. He says the episodes do not seem to be occurring more frequently or with less exertion. Okay. She has no history of serious illness and doesn't take medication, no smoking. Her pulse is fine, blood pressure high. Cardiac exam shows no abnormalities, and ECG is fine. The patient is reluctant to undergo catheterization. Which of the following is the most appropriate next step in management? Mm, Ready?
Yes.
Oops.
Okay. It's a ETT, exercise stress test. Exercise exercise stress test is the next step in appropriate management. In exercise stress test is next appropriate step in the management of patient who has symptoms that are consistent with angina pectoris. Angina is classically described as substernal pressure that occurs with exertion or strong emotional stimuli, and strong emotional stimuli and resolves with rest. It is most often a result of obstructive coronary artery disease and occurs as a result of mismatch between the amount of the oxygenated blood required to perfuse the heart during a period of stress and the amount of blood that is able to bypass blockage within the coronary arteries. The gold standard is coronary catheterization, which can identify the precise location and extent of the coronary plaques, but many patients first undergo the stress testing for risk stratification. There are vigorous type of stress testing, each with differential indication and sensitivity, but common varieties include exercise treadmill stress test, exercise nuclear stress test, pharmacological stress testing. All patient with obstructive coronary artery disease should be started on aspirin and a statin. Symptoms of angina can be treated with beta blockers, calcium channel blockers, and nitrate.
Next.
Why
58
it
men
is
comes to office.
testing, like why it is not giving drugs?
What do you mean?
Like ECG is normal, isn't it?
Mm-hmm.
So why we should not, as and he is reluctant to do the, what can I say? He's reluctant to do the cardiac catheterization, isn't it? Like
Mm-hmm.
he does not want to do the coronary angiography, catheterization.
Mm-hmm.
So
Mm-hmm.
shouldn't we just give the drug like aspirin and metoprolol therapy?
But you have to confirm that he has, right? That he has the coronary artery disease. And then you give the drug.
And if ETT is normal, then what
Then
ETT will show, like if there is an ischemia or not, isn't it? Like any sort of teen version.
yeah, the stress test will show. And then if it shows, that's when you can start him on the drugs.
If stress test is normal, then sometimes the like substernal chest pain and with exertion not always comes with the angina pectoris, isn't it? Sometimes the GI pain, the GERD can come with
Uh-huh.
the
Uh-huh.
substernal chest pain and exertion.
Uh-huh. Uh-huh.
Then,
Then you're not going to start the drug. That's why you do the test. If it's not angina, then why are you starting the drug then?
okay.
Or maybe I'm not understanding your question.
Oh, yes, I got,
That
I got it.
you
I
got
got
it.
my
Okay.
point.
Okay. 58 men comes to the office because 5-day history of elevated home BP readings. He has a 10-year history of hypertension. Since treatment with lisinopril was started 10 years ago, his previous home and office blood pressures have been less than 140 over 90. 10 days ago, the patient dentist initiated acetaminophen, amoxicillin, naproxen regimen for abscess tooth. The patient currently is asymptomatic. Blood pressure measured today is at 160 over 95. Reminder of the vital signs are fine. Physical exam is fine. Which of the following is the most likely expansion for these patients' findings? he started NSAID, so NSAID is gonna make mhm, antagonist
Is
effect of
it due to
cytochrome.
naproxen, the initial sudden
Yeah, I'm
rise of the blood
thinking
pressure?
it is prostaglandin. Yeah, diminish absorption of the synapse, exercise adrenergic, huh? Inflammation of the renal interstitium, decrease prostaglandin synthesis, must be that
The mechanism of the naproxen, isn't it?
naproxen, NSAID,
NSAID.
yeah, prostaglandin, yeah, okay,
Okay,
ready?
we are right. Yes. When patients present with new signs and symptoms, a review of recent medication, a review of recent medication changes, a review of recent medication changes is necessary to determine whether there is a drug-drug interaction or medication adverse effect. The most likely explanation for this patient's recent asymptomatic hypertension is drug-drug interaction between the lisinopril and the naproxen. Lisinopril and the naproxen. Okay. Naproxen and other non-steroidal anti-inflammatory drugs are inhibitors of cyclooxygenase enzyme, which have a primary role in the synthesis of the prostaglandin and the prostacyclin. These molecules play key roles in the modulation of pain sensation and thermoregulation, the maintenance of the gastric mucosal barrier, and molecules play key role in the modulation of the pain sensation and the thermoregulation, the maintenance of gastric mucosal barrier, the regulation of the renal blood flow. NSAID use can precipitate acute kidney injury because decreased prostaglandin synthesis, which would otherwise promote renal afferent arterial vasodilation and renal blood flow. This can cause worsening hypertension, especially in patients taking ACE inhibitors such as lisinopril. As a result, autoregulation mechanisms, increasing blood pressure as a means of increasing renal perfusion.
Okay, next.
Yes, yes.
Uh, yeah. Previously healthy 32 woman come to physician because mild headaches and weakness for 3 months. Pulse is fine, BP is super high, exam shows what happened? Exam shows no other abnormalities. Serum studies, sodium is fine, chloride is fine, potassium is low, bicarb is high, urea is normal, and creatinine normal. Which of the following is the most diagnosis? Headache and weakness. What did I say? Potassium is low, heart is high. Leukocytoma, hyperaldosteronism, androgenic Addison disease,
Isn't it like, mm, where is
adenoma, adenoma with
hyperaldosteronism cons hypo
but shouldn't
primary hyperaldosteronism comes with like stria, like skin finding, isn't it? Cushing also has some sort of skin findings,
have a
but
headache,
there is headache. You
uh,
are thinking about pheochromocytoma, episodic hypertension, but
hypertension, Weakness? No,
But
I'm not
not
thinking.
hypokalemia, isn't it? Potassium is
Yeah,
low.
yeah, no. Hyper Cushing syndrome. Cushing syndrome, adrenal adenoma. They kind of show the same things. Ah, hydrogen. It's not that this one Castania. This one sodium will be potassium will be high.
Bicarbonate is high too. Why this bicarbonate is high?
Bicarbonate is high. Bicarbonate is
This
high.
may be another clue. I think so.
It's a clue. I
Like
just don't.
hypokalemic, hypochloremic.
Jesus, this is a hard thing. Um, I'll just go with. I'll just go with.
Hyperaldosteronism.
Hyperautism, it doesn't make sense because. Okay.
There is no stria. I got it.
Yeah.
But maybe it is the answer.
Okay. Okay.
Okay. So
Go ahead.
sorry.
Yeah. Uh
Okay,
huh.
you're
Go ahead.
right. Hyperaldosteronism is the most likely diagnosis. Hyperaldosteronism is a relative common cause of secondary hypertension in young patient and may present with isolated hypertension in the absence of electrolyte abnormalities, or may present with hypertension, hypokalemia, and metabolic alkalosis. Hyperaldosteronism can result from excess secretion from unilateral adrenal adenoma, but often results from bilateral adrenal hyperplasia. Aldosterone acts to upregulate the action of the sodium channels in the cortical collecting tubule, resulting in increased sodium resorption. The intracellular shift of the intracellular shift sorry the transcellular shift of sodium causes the lumen to become electronegative and thereby stimulates the secretion of potassium into the urine, resulting in urinary wasting resulting in urinary wasting of potassium. Metabolic alkalosis is the result of excess hydrogen ion secretion stimulated by the hypokalemia and through the direct effect of aldosterone on urine acidification. Diagnosis is made by measuring measuring serum renin and aldosterone, which demonstrate an abnormality increase aldosterone undetectable in the renin concentration. Okay. Do you want me to
Spirit
read the other
CD.
options? Okay.
Yeah. Uh huh.
Okay. C. Androgenital syndrome. Androgenital syndrome usually refers to congenital adrenal hyperplasia secondary to 21-hydroxylase enzyme deficiency. Patients presence at birth with ambiguous genitalia. Patients presence at birth with ambiguous genitalia and sometimes with a salt losing adrenal crisis. Cushing syndrome is caused by an excess of cortisol production either from a pituitary or a non-pituitary tumor that secretes ACTH, or adrenal tumor that secretes cortisol. Patients present with weight gain, abdominal striae, hyperglycemia, and hypertension. And pheochromocytoma is usually caused by adrenal or paraaortic tumor that produce an excess of metanephrine. It presents with episodic hypertension, tachycardia, and anxiety. Okay.
Got it. 15 boy brought to office by mom because of 2 day history of moderate joint pain, fever, headache, fatigue, and blotch over his right shoulder blade. Blotch. The blush began as a small red papule and gradually spread. The patient says he thinks he was bitten by a tick a week ago. His temperature is a bit high, other vital signs normal. Exam shows 15 centimeter erythematous area over the right scapula. Which of the following is the most appropriate next step in patient care? Joint pain, fever, headache.
Should we give the treatment or should we do some diagnosis?
So we could.
Examination show 15 centimeter erythematous area. Is it uh, like Borrelia burgdorferi, Lyme disease tick bite, isn't it?
The only thing that it can be, penicillin, what would that be? Syphilis? It doesn't make sense for syphilis. Proteus, I don't think Proteus has anything to do with, yeah, I don't think. So it's either the serum titer for Borrelia or doxycycline. Should we start with doxycycline? I guess. Ready?
Yes,
Okay.
yes, you are right. Okay, Lyme disease is a tick-borne disease caused by Borrelia burgdorferi endemic in the northern US. In the northeastern US, in its early stage, it causes erythema chronica migrans, which is an expanding rash with a central ring-like clearing. Expanding rash with a central ring-like clearing. It can also be associated with flu-like illness and arthalgia. The early stage of Lyme disease can be treated with doxycycline, which acts by preventing the attachment of amino acyl tRNA ribosomes. Side effects of tetracycline antibiotics include gastrointestinal distress, photosensitivity and in children, discoloration of the teeth and inhibition of the bone growth, which contraindicates the use of the doxycycline in pregnancy. Later stages of Lyme disease are characterized by carditis, AV block, facial nerve palsy, migratory arthalgia, and if left untreated, encephalopathy and chronic arthritis. The later stage of the Lyme disease that affects the heart and the central nervous system are generally treated with parenteral ceftriaxone. Okay, serum titer of the antibody to the Borrelia burgdorferi is not necessary in this patient. History and physical examination adequate for establishing the diagnosis of a known tick exposure. Characteristics rash serum studies is often negative in the early phases of the disease, but antibodies. Okay,
So first you use doxycycline and then ceftriaxone. Okay. Next. 65 men brought to the physician because for their history of increasing severe upper back pain, pain with urination, nausea, fever, and chills for days. During the past 2 days, he has been able to ingest only clear fluid. He has 5 year history of BPH and with the 5 year history of hypertension, medication tamsulosin is inoperable. He's alert and cooperative. He has fever, pulse is fine, irregular, respiration fine. BP a bit low. Exam shows dry mucous membranes. Abdominal exam is fine. There is cost of a severe angle tenderness bilaterally. Which of the following is the most appropriate next step in management? Mm. Ready?
Yes.
Mm. Oops.
Okay. Acute pyelonephritis is a urinary tract. Acute pyelonephritis is a urinary tract infection that has spread to the kidneys, which is characterized by flank pain, fever, chills, nausea, vomiting, costovertebral tenderness on physical examination. Infection, urinary tract infections are much more common in women as a result of the shorter urethra and favor, favorable regional environment for bacterial growth. In men, BPH can contribute to BPH can contribute to urinary retention and incomplete bladder emptying, increased risk of urinary tract infection if untreated. Bacteria can travel up to the ureter to infect the kidney, resulting in pyelonephritis. Immunolysis typically discloses positive leukocyte esterase and nitrate along with many WBC and WBC casts on microscopy. Treatment includes antibiotics covering common pathogens. Urinary tract infections are commonly caused by E. coli and gram-positive E. coli and gram-negative enteric flora, but some positive organism may be the culprit. In patients who are able to tolerate oral medications and are otherwise well appearing with stable vital signs, outpatient management with oral antibiotics is adequate. However, in patients who are unable to tolerate oral antibiotics, are not well appearing, and are septic, IV fluid and antibiotics are indicated. If such patients do not improve clinically, admission may be necessary.
You read DE,
Yes,
this one.
oral antibiotic therapy would be inappropriate in patients. Oral antibiotic therapy would be inappropriate in this patient who has only been able to tolerate clear fluids and may not be able to tolerate oral antibiotic. Oral antibiotic therapy would be inappropriate in this patient who had only been able to tolerate clear fluid. Many may not able to tolerate oral antibiotics.
Okay.
And the patient is showing signs of sepsis, fever, borderline hypertension, tachycardia, IV antibiotics, fluid administration for appropriate dissociation. Okay, can you give me 5 minutes?
Good. Yes.
Okay, I'm coming.
For follow-up exam because of ongoing disabling back pain. She rates the pain as a 10 out of 10. Physical exam and X-ray obtained during the past 3 years have shown no abnormalities. Back hygiene education, physical therapy, and acetaminophen and NSAID drugs have not provided relief. She believes that something terrible is going on despite being told that by an orthopedic surgeon that there is no significant pathology. She reports that she has been She has seen a psychiatrist a few times but found her visits unhelpful. She has no other history of serious illness and doesn't take meds. She appears anxious and expresses high concern about her inability to stop her pain. Vital signs are normal, physical exam fine. Which of the following is appropriate? Next step in management. Jesus. No, I cannot remove it. Okay.
Okay. Okay. Schedule frequent follow-up examinations. In somatic symptom disorders, patient is preoccupied with one or patient is preoccupied with one or more somatic symptoms such that these symptoms disrupt patient's daily life. These symptoms may or may not originate from the underlying disease, though are typically unsocially produced or exacerbated by psychological factors such as stress. Patients with somatic symptom disorder excessive time excessive time and energy to these symptoms and related health concerns, repeatedly going to the doctor. Somatic symptom disorder typically demonstrate chronic fluctuating overcourse. Management of the somatic symptom disorder centers around regular primary care follow-up that targets coping skill, provided reassurance, and avoids unnecessary tests. Okay.
Nice. 78 woman brought to office 2 hours after the onset of shortness of breath, lightheadedness, palpitation, and fatigue. She has a history of symptomatic heart failure and hypertension. Medications is sildenafil and aspirin. Temperature is fine, pulse is high, respiration high, blood pressure low, pulse oximetry on room hair shows oxygen saturation 92, bilateral basilar crackers are her, S3 also is her, there is edema of lower extremity, no other abnormalities noted. Echo 2 months ago showed an ejection fraction of 35. ECG obtained 2 months ago showed no abnormality. ECG obtained today shown. Most likely explanation for these findings. I cannot see shit on the ECG.
Which finding? Like low ejection fraction, this one.
I'm thinking the shortness of breath, lightheadedness,
Like heart failure.
palpitation, and fat. I'm thinking, yeah.
They are asking why heart failure.
I'm thinking. I mean, what findings? Because she kept complaining of that, so I'm thinking that's what they're asking.
Okay.
Okay. Oh,
We both thought about the shocks, like that chart. Right sided preload is increased, left sided preload is increased, isn't it?
left-sided preload is increased. Left-sided preload, yeah.
Okay. It is left ventricular, okay, decreased left ventricular filling. So this ECG, irregular, narrow complex tachycardia, lack of T waves, atrial fibrillation, heart failure, and atrial fibrillation share the heart failure and atrial fibrillation share many common risk factors, each predisposed to development of the other. Atrial fibrillation with rapid ventricular response, heart rate more than 100 beats per minute, and can cause acute decompensation of the heart failure as a result of decreased left ventricular filling. In normal sinus rhythm, an ideal stroke volume is achieved as the diastolic filling time is sufficiently long to allow the ventricle to fill completely before contraction occurs. In atrial fibrillation with rapid ventricular response and in other tachyarrhythmia, diastolic filling time is reduced, so the amount of the blood in the ventricle prior to the ventricular systole is less than would exist had filling time been sufficient. This results in a reduced stroke volume. This results in a reduced stroke volume, decreased cardiac output, symptomatic heart failure, and potentially hypertension and hemodynamic instability in severe cases. Okay, why not increase afterload? Increased afterload is less likely to explain the patient's acute decompensation, especially in the absence of systemic hypertension or known aortic stenosis or coarctation of the aorta that may have been noted of prior echocardiography. Can you please explain?
Oh, they're just saying if it was increased after all, the blood pressure will be high. But here the blood pressure is low, so it cannot be increased after load. So it makes
And
sense.
okay,
Yeah, I think that's just the reason for B. Can you read E?
yes. Why it is the answer like decreased left ventricular? Is it due to atrial fibrillation causing heart failure?
Yeah,
Like
yeah, they're saying yeah, that's why they gave us the. I guess we didn't look at the. I never looked at the ECG, but we didn't look at the HCG. There is no P wave, so it's AFib, and then so it's AFib plus heart failure both together. So the heart doesn't have time to fill the left ventricle because it's the AFib, the ventricle is responding fast. So there is stroke volume keeps going, but there is no time for diastole for the ventricle to fill. So the stroke volume is low. The ejection fraction of the blood is low. That's kind of what they're saying.
okay,
Does it make sense? Yeah. Does it make sense a bit?
yes.
Okay. Can you read E?
Increased venous tone would result in increased venous return of the heart, like increased preload, because of a greater pressure gradient, because of a better uh, because of a greater pressure gradient between the venous system and the right atrium. Increased preload would result in increased cardiac output. This patient is displaying signs and symptoms of insufficient cardiac output.
77 woman comes to physician for her son with her son for follow-up. The woman. 2 weeks ago, she was discharged from the hospital where she was treated for chest pain. And Disney and was diagnosed with left ventricular dysfunction. She's currently asymptomatic and is able to walk up 3 flights of stairs without symptoms. And she has hypertension, hyperlipidemia. Before hospital admission, meds were atenolol statin, aspirin, and calcium supplementation. On discharge, lisinopril and furosemide were added to the medication regimen. She lives alone. Pulse is that's fine. Blood pressure, that's fine. Exam shows no abnormality. The patient's son is concerned that his mother is confused by her med regimen. Which of the following is the most appropriate next step in management? Ready?
Oh, yes. Polypharmacy is a common problem among elderly patients. Patients taking multiple medications are often understandably confused to which medications are for which conditions and how to take each medication when medications are discontinued or changed. The patient may be inadvertently continue taking incorrect medication or doses. Patients may also have multiple prescribing providers who are unaware of their medications. The patient taking the who are unaware of the medications the patient is taking. In this case, having the patient bring in all the current medication for review will yield the safest outcome. By doing this, the physician can confirm the patient not only has the correct medication but also takes the correct dose at the correct time of the day. That will relieve the patient's confusion and also decrease the risk for adverse effects from taking wrong medications or wrong doses. Okay,
Can you read B and E?
yes. Contacting contacting the hospital pharmacy to reconfirm all pre and post medication admission and doses is only accurate as far as the hospital records are accurate. Medication reconciliation is an important part of admitted a patient to the hospital. However, the patient may have other medications at home they are still taking but neglected to report. So, having the patient bring in all of their medication will be more reliable way to counsel this patient. And the option E,
Mhm.
reviewing the medication list on the clinical chart is inadequate. Reviewing the medication list on the clinical chart is inadequate because it may not complete or accurate. Furthermore, by simply reviewing the list and the patient may leave the office just as confused as when she arrived. Patients are likely Reviewing the medication list on the clinical chart is inadequate because it may not complete or accurate. Furthermore, by simply reviewing the list, the patient may leave the office just as confused as when she arrived. Patients are likely to recall the counseling pertinent to each medication better if they are simultaneously be shown the bottle, pill color, pill size, and prescription. Okay.
62 woman comes to physician because of a lesion on her right cheek. She has had the lesion for 1 year, but it has gradually increased in size over the past 6 months. She has history of heavy sun exposure. Exam shows 12 mm lesion in the right cheek with raw, pearly border, telangiectation, and small central cross. Which of the following is the most likely diagnosis?
Isn't it specific like BCC?
Right, basis,
Feeling like, don't know.
pearly border, raw cheek, telangiectasia. Yeah, telangiectasia. But
Telangiectasia.
BCC
Yes,
BCC doesn't have a small central cross, does it?
PCC does not.
Have the small central cross. Or no? Does it have the small central cross?
Maybe, maybe. You are thinking about SCC.
Yeah.
It may happen. I don't know. Small cell carcinoma is associated with heavy sun exposure.
Okay, let's check. Ready?
Yes,
Ah, you were right. BCC.
these things are very, very confusing.
You are.
That's why I always try to remember the cheat code, uh, like the
The
specific word.
telangiectasia.
Yes, telangiectasia, pearly border, rolled pearly border with telangiectasia goes for BCC. Okay, basal cell carcinoma, basal cell carcinoma or epithelioma is the most common form of skin cancer and is derived from the basal cells of the epidermis because of mutation in the sonic hedgehog pathway or p53 tumor suppressor gene. The primary risk factor for developing basal cell carcinoma is ultraviolet light exposure. Is the ultraviolet rays exposure, uh, though age, fair skin, and family history also contribute. Basal cell carcinoma typically presents as pink, pearly papules or nodules with a rolled border with a central ulceration, most commonly on the sun-exposed areas of the head and neck. Subtypes of basal cell carcinoma include those that are less invasive, such as superficial and nodular, and those that are more invasive, such as infiltrative and morphiform. In all subtypes, the risk for metastasis in all subtypes. I got lost. Okay. Subtype in all subtypes, the risk for metastasis is extremely low, though the tumors can invade locally and cause significant tissue damage. Treatment of basal cell carcinoma requires surgical removal either by excisions or more micrographic surgery. Okay.
Mm-hmm.
এরা তো এখন তোমাবা
You want to see the picture? It says it looks like a volcano. Okay. Basal
This has
cell
a
carcinoma.
specific like thing, volcano-like appearance.
Mm-hmm, mm-hmm, mm-hmm,
And melanoma is ABCDE.
mm-hmm. Okay.
And the metastatic squamous cell carcinoma associated with like what can I say? Squamous cell carcinoma, there is some association like
Burn. Okay.
burn thing.
Okay. Next. 40 men has had fatigue for 2 weeks and progressively severe shortness of breath over the past 24 hours. Tired for 2 weeks, shortness of breath. Okay. He has been well until 3 weeks ago when he developed fever, sore throat, and rhinitis. Exam shows distended nerve, veins, and basilar crackles. S1, S2 normal, S3 gallop is heard. Um, oh, jeez. Which of the following is the most likely diagnosis?
Standard name invasive.
Ready?
Wait 1 second.
Okay.
Is it myocarditis?
That's what I pick, yeah.
Okay, very confusing. Okay, this patient most likely diagnosis is viral myocarditis. Myocarditis refers to inflammation of the cardiac myocytes. Notable cause of viral myocarditis is Coxsackie B virus, parvovirus B19, and human herpes virus 6, and HIV. Patients typically present with fever and signs and symptoms of characteristics of the heart failure, including volume overload, jugular venous distension, as in this patient with chest pain, shortness of breath, pulmonary edema noted as crackles auscultated in the lungs, and S3 gallop on physical examination. In addition, patient may also present with arrhythmia, exercise tolerance, syncope, hypotension, tachypnea, tachycardia. Depending on the underlying pathogen, there may be viral prodrome preceding the development of heart failure, as in this patient who displayed symptoms of an upper respiratory tract infection 3 weeks before the presentation. Diagnostic study typically show increased cardiac biomarker concentration, troponin, and a normal ECG, normal chest X-ray. However, chest X-ray may show pulmonary edema or pleural effusion depending on volume status. Treatment is supportive. Okay. Some patient may require diuresis, and depending on the severity of the pharmacology. Okay.
26 man comes to the office for health maintenance exam. Describes drinking at least 6 beer every night during the past 2 years. He has no history of serious illness and no medication. Vital signs are normal. Physical exam normal. He is concerned about his health and is thinking about quitting drinking alcohol, but he's not sure if he's ready. Serum labs is few, alcohol is high. Let me double check. It's normal. AST and LT are high. Yeah. Which of the following strategies is most likely to motivate this patient to change his behavior? Ready?
Okay. That's okay. Motivational interviewing, a strategy in which physicians determines and then guides the patient to reflect on their willingness and motivation to change, is helpful when discussing health behaviors with patients. In this case, by acknowledging and the discrepancy between the patient's drinking and his desire to quit, the physician is helping the patient realized that the difference in current behaviors and the future goals. In any discussion, as in any discussion with a patient, including open-ended questions will be helpful in fostering discussion about the patient's motivations to change his behavior. For example, the physician could also reasons ask his specific reasons are for wanting to quit drinking alcohol, or for what barriers lead him not feeling ready to quit drinking. Even if the patient is not ready to stop the behavior, the physician should be direct and clear in explaining the risk without making the patient feel guilty or defensive. Then emphasize their willingness to partner with the patient when they have decided to change. Okay.
29, man comes to physician because 3 week history of increasing severe right shoulder pain. He says the pain begins as an ache at the front of his shoulder and occasionally radiates down the front of his arm. He works as a lawyer and plays softball every weekend on his firm teams. He lifts weights at the gym. He sleeps well and is able to perform his usual work activity. Exam shows tenderness to palpation over the right bicipital group. Okay. Flexion at the right elbow against resistance produces the pain. Which of the following is the most appropriate initial step in management?
Flexion at the right elbow. Flexion right elbow against resistance causing pain.
The right bicipital group. I don't know what that means.
Okay.
Flexion of elbow. Okay.
Is it what is your diagnosis? Is it bicipital tendinitis?
I don't think so. What? No? It's like, I don't know. I really don't know. What's the diagnosis? I really don't
I have diagnosed right, but we give
know.
the wrong answer.
What did you diagnose? Oh, yeah, biceps tendinitis. Where is the right bicipital?
Bicipital tendinitis.
Oh,
We have
what is the
diagnosed
right
right,
bicipital?
but we
Oh, okay. I didn't even know where was that. Okay.
recommend for rest from softball and weightlifting. Okay. Recommend for rest from softball and weightlifting is the next step in the management for this patient with symptoms and examination findings most consistent with biceps tendinitis. Most patients with biceps tendinitis have a history of repetitive throwing, pulling, lifting, repetitive throwing, pulling, lifting, and usually present with anterior shoulder pain. The biceps tendon consists of one short and one long tendon. The long head of tendon usually originates from the edge of the glenoid and runs anteriorly through the intertubercular groove of the humerus, while the tendon of the short head originates at the coracoid process and travels medially, where it eventually connects to the short head of biceps muscle. The distal insertion of the biceps is at radial tuberosity is shared by both long and the short head of the biceps muscle. The distal insertion of the biceps is at radial tuberosity is shared by both long and short head of biceps muscle. Injury to the long head tendon is more common than injury to the short head. Injury to the long head is more common to the injury to the short head because of anatomic location. On examination, patients will have pain upon palpation, the tendon pain upon palpation the tendon within the intertubercular groove located along the anterior humerus. Additionally, as the biceps muscle is primarily responsible for flexion of the arm when supination, flexion of the arm when during supination, and conducting these movements against resistance produce pain. Conservative conservative management focus on rest and gradual reintroduction of the activity. Okay, why it is not physical therapy? Physical therapy is most likely to exacerbate the symptoms of the biceps tendonitis. The most appropriate intervention at this time is activity modification and rest.
Okay. 14. 56 men with hyper. Are you still there?
Yes,
Okay.
are you
Fif-
tired?
No, no, because it became quiet. So I was like, wait, maybe the call is the call cut and I'm here just talking. Anyway,
I'm quiet
56.
as because I'm getting
Uh-huh.
wrong. Like
Like,
the previous question, like the this like previous question, the physical therapy I got wrong. There are some like question number 12 I got wrong. I don't know why I am unable to think this kind of question.
hmm.
Very poor in behavioral science or social ethics.
But that's not ethics. Is this ethics?
This is type of
The,
ethics question.
the physical, no, the physical
No, no,
therapy
no.
doesn't.
This not this one. The
Uh-huh.
12 one.
Oh, wait, which one did you choose for this one? For the 12th one?
B.
The patient to accept the label that he's an alcohol. Oh, no. Okay. Hmm. Yeah. Okay,
I
okay.
choose a very funny option sometimes. And then
Hmm.
when I see the answer, then I understand that why I.
And you make, oh, it makes sense. Oh, okay. Well, I don't think, no, I don't think if you ever find this question, I'm pretty sure you're never gonna get it wrong again. Like, yeah, I'm pretty sure.
Okay.
Okay. 56 men with hypertension comes to office for routine. He says he feels well, his only medication is Sinopil. He follows a low cholesterol diet and walks 30 minutes every day. Temperature is fine, pulse is fine, respiration fine, BP fine, BMI fine, exam shows no abnormality, labs, cholesterol, it's fine, borderline. HDL is fine, LDL is fine, tags is, wait, what did I say about cholesterol? Cholesterol is fine. Tags is fine. His estimated 10-year atherosclerotic cardiovascular is 8.3, so I guess it's high. Addition of which of the following is the most appropriate next step in pharmacotherapy to prevent cardiovascular mortality in this patient? What is he taking? Just listen up well. He is 40 and he has,
There are three criteria.
I forgot that you always remember those criteria.
Age more than 40, LDL more than 190, and ASCVD more than 7.5.
Okay.
He has ASCVDs more than 10 years. Atherosclerotic cardiovascular risk factor is more than 8.3. It is calculated. There is a calculator. You can use it. for
Okay.
diagnosing this. So, okay,
Perfect. Perfect.
okay. This patient, this patient's screening lab studies show increased total serum cholesterol and LDL concentration. Patients are typically asymptomatic, and the diagnosis is made by routine screening panel. These patients should be evaluated for secondary causes of hyperlipidemia, checking thyroid function, hemoglobin A1C, chemistry panel, urine analysis to assess kidney function, kidney function, and encouraged to continue his cholesterol diet and daily physical activity and maintain a lower BMI. He should be started on lipid lowering pharmacotherapy with an HMG-CoA reductase HMG-CoA reductase inhibitor such as atorvastatin, given increased 10 years atherosclerotic ASCVD risk. There is strong benefit with statin therapy for patients who already have clinical ASCVD history of acute coronary syndrome, myocardial infarction, peripheral vascular disease, cerebrovascular accident, diabetes mellitus, LDL, cholesterol greater than 90 with an estimated 10 years ASCVD score greater than 7.5. Okay.
77 man brought to physician as a new patient by his wife and adult children. He received the diagnosis of dementia, Alzheimer type, 1 year ago and is aware of his diagnosis. His family reports that he enjoys gardening and reading but is unable to manage the money. He has no other serious illness. He has not felt depressed, vital signs normal. He's alert and oriented, but not to time. His mini mental status exam 24 out of 30. The remainder of the exam is fine. An advance directive has not been established. Which of the following is the most appropriate next step in discussing advanced care planning?
He
One
has
of your
Alzheimer disease. Okay, got it.
Mhm.
His MMSC mini mental state scoring is not that bad, and but he is not in a delirium state. He can take his own decision, isn't it?
uh, he said he's not oriented to.
If the patient is in a delirium state, like if the patient do not understand what we are talking about, then I think that discussion is the part.
Okay.
What do you think? I
Let's
don't
see.
know. If it is wrong, it's not
I
my.
mean, it's okay. It's okay. But I think I mean, the only thing was when they say he's not oriented to person and time, so he's not mentally capacitated. So I thought if that meant he's not mentally. But maybe you're right. I mean, he may not be oriented, but he's not delirious. Maybe that's you know. Um, yeah, it's
Okay,
either that or get the court order, but I don't think it's get the court order. Let's see. Yeah, you're right.
okay. Patients with dementia, patients. Okay, patients with dementia difficult challenges. Patients with dementia face difficult challenges as their decision-making ability declines through the progression of the disease. Advanced planning for the later stages of the dementia should take place through discussion between the patient, their family, their physician. Patients should be encouraged to participate in their own medical decision making and to exercise their capacity to the greatest possible extent. Patients' participation in this discussion allow a patient to express their own goals, beliefs, values, and preferences. Advanced care planning is a continual process and should be revisited routinely as or as a patient's clinical condition changes. This patient is experiencing mild cognitive function and should be involved at the time in his own care planning. Okay.
Mm-hmm. You say you got that one. Uh, 62, 64 African American woman. Oh, what happened? African American woman with diabetes comes to physician for routine. The patient is concerned about increasingly dry skin of the feet. Why is my thing doing that? She takes metformin, atorvastatin, and enalapril. She has been trying to improve her diet overall adherence to diabetic treatment plan, but following a, a carb counting plan. BMI is pretty high. Vital signs are normal. Physical exam of the feet shows linear, white, scaly areas with moist, raw skin between the toes. Hmm. What's the most appropriate treatment for this patient rash?
What
Wait,
is the diagnosis?
I don't even know. What is it? White?
It does not look like scabies, isn't it? Scabies is not like that.
No, because it will be itchy, but that's not itchy.
It looks like a chalky lesion, chalky
Like,
white,
huh?
chalky white lesion. Where is the chalky white lesion?
Cotimazole is for the fungus.
Antifungals, fungal. Okay. He has
Mm,
diabetes.
he has diabetes. Okay. What's mupirocin for?
Mupirocin.
That's for
Mupirocin,
the
mupirocin is for the that honey crusted lesion.
honey crusted lesion. Oh. I get what you say. Okay.
Is it
Ready?
like fungus is
I think so. It's the only thing that makes sense. Hydrocortisone, why would you put steroids there? Don't make sense. Mupirocin, we know it's not the honey crust deletion. That's a step something. Petroleum jelly, I don't even know why petroleum jelly. And
petroleum
the
based jelly is like
I don't,
dry
I
skin
don't
for like dry skin, not for this. Okay.
oh, well, the skin is dry, but yeah. Okay, let's see.
But the skin is full filled with fungus.
Yeah.
Okay, it is Tenia pedis.
Oh, that looks. I don't think I ever seen a picture of it. In your page, so maybe yeah.
Okay. Okay, Tinea pedis is a common superficial cutaneous fungal infection caused by dermatophytes, most commonly Trichophyton rubrum. By definition, tinea pedis involves the feet, while dermatophyte infections of the body, tinea corporis, groin, cruris, scalp, capitis, and nail unguium are separately named. The most common presentation of tinea pedis is a moccasin pattern. Tinea pedis is moccasin pattern distribution of the white scalp, moccasin pattern of the distribution of the white scalp around the edge of the sole. Another common presentation is macerated patches between the toes. Macerated patches between the toes as seen in this patient. Macerated patches. Okay, comorbidities which decrease the immune system function. Diabetes mellitus increase the risk of dermatophyte function. Additionally, dermatophyte infection provides entry of the bacterial infection, which is which in patients with diabetes mellitus and can lead to difficult to treat infectious disease such as osteomyelitis. Potassium hydroxide preparation will show hyphae fungal culture. A fungal culture may also be performed to confirm the diagnosis and determine the causative species before initiating empiric treatment. First-line treatment of the tinea pedis is topical antifungal using clotrimazole, terbinafine, ketoconazole combined. Topical antifungal and corticosteroid products are not advised in the patients with tinea pedis or any dermatophyte infection given likelihood of the worsening of the condition uh, and disease with topical corticosteroid. Why I emphasize these word, uh, do you know? Because
Mhm.
in our country, like some of the dermatologists also use these type of things. Like they give antifungal along with the this drug, like along with the corticosteroid, so their dermatophyte infection is not improving. Okay.
Can you read A? I mean B, sorry.
Yes, hydrocortisone is a topical corticosteroid and will worsen tinea pedis by inhibiting the inflammatory response necessary to eliminate the infection. Tinea-related topical corticosteroid is often referred to in tinea incognito based on severe and unusual morphologies that infections take and after treatment with topical. Okay, that one is different, like tinea incognito. On that case you can give the topical corticosteroid. You got my point. You can see the
Mm-hmm.
tinea incognito. Tinea incognito is like
Mm-hmm.
kind of severe manifestation, you can say it in that way.
Mm-hmm.
So on that uh, perspective you can use corticosteroid
Okay,
on after
got it.
treatment with topical corticosteroid. Okay.
19 women comes to office because 4-hour history of severe right lower abdominal pain, heavy vaginal bleeding, lightheadedness, and dizziness. Last menstrual period was 2 months ago. She has no history of serious illness, no medication. She's been active sexually with one male partner for 2 years. They use condom inconsistently. Temperature fine, pulse high, respiration normal, BP low while sitting, and even lower uh, is low. Abdominal exam show moderate tenderness to the palpation of the right lower quadrant, but no rebound. Pelvic exam shows a small pool of fluid in the vaginal bone. Uterine size at the upper limit of normal and moderate tenderness to palpation of the right diaphragm. No abnormalities are noted. No other abnormalities are noted. ACG is positive. What is the diagnosis? Hmm, upper limit of normal. Oh, hmm.
Is it ectopic?
Yeah, I was between that and threatened abortion, but I think it's a topic. Okay, let's see. Ready?
Yes.
Yeah, it's a topic. Yeah.
pregnancy is caused pregnancy is suspected when there is missed or delayed menstrual period. Ectopic pregnancy is an abnormal pregnancy in which fertilized ovum implants in the fallopian tube, more common on the ovary, within the peritoneal cavity, or in any non-endometrial location. Vaginal bleeding. It often presents with vaginal bleeding and abdominopelvic pain. Rupture. Complications of the ectopic pregnancy include rupture, bleeding, and hemoperitoneum. This can lead to hemodynamic instability with tachycardia and postural hypotension initially, as in this patient, followed by profound hypotension when blood loss exceeds the body's compensatory mechanism. Patients with rupture ectopic pregnancy may have diffuse and or localized abdominal tenderness and may not have rebound tenderness. A ruptured ectopic pregnancy is a surgical emergency, often requires laparoscopy with salpingectomy. Hemodynamically unstable patient, as in this case, require immediate fluid resuscitation and potentially transfusion along with other operative control. Okay.
Okay. Next. 20-year-old college student comes to student health service because of insomnia, nausea, indigestion, periodic anorexia for the past year. She has had a 10-pound weight loss for the past month. Um, she worries about her physical problem and feels that her friends are avoiding her because she's not worthy of the friendship. She states that her grades are falling and she has dropped out of her sorority. She denies suicidal ideation but states that she cries daily for no apparent reason. BMI is super low. Pulse is fine. Respiration fine. Exam and lab studies are normal. Which of the following is the diagnosis?
Okay. BMI is less than 18.5, so anorexia.
Oh, did not see that one coming. Lord Jesus. I replied in like 2 seconds. I didn't even look at the question. Once I saw the BMI, I was like, okay, let me just go
So
ahead.
I have told you yesterday, premeditated answer. Okay,
I
in
did not.
this question, okay, we need to find out the 5 points of the MDD. This patient has insomnia. Is there any insomnia?
Yeah, she has
Okay,
insomnia.
insomnia, weight loss. Okay, weight loss, one of the cause of the MDD. Avoiding worthy of feeling like feeling uh, him myself not worthy enough. So 3.3 his grades are fallen, dropped out, denies suicidal ideation. He has only 3 point. There is only
No, he has five. He has depressed mood, weight
mood,
loss, feeling
feeling
of
of
not
worthlessness,
loss of interest, and what is it? One, two, three, four.
and the
Uh,
depressed mood.
yeah, I already counted. One, two, three,
So
four.
they don't have all the 5 points.
Well, okay, yes.
These things are very problematic. Okay,
Oh, the insomnia. Sorry. Yeah, they
yeah,
didn't count it. He has depressed mood, weight loss, loss of activity, and insomnia. Sorry.
insomnia, 5 points, yes.
Mhm.
So, so whenever we find the 5 points, then MDD is the answer, whatever it takes. Okay, this patient, this young adult patient who presents with depressed mood, weight loss, feeling of worthlessness, loss of interest in activities, Likely experiencing MDD, major depressive disorder, requires the presence of at least 5 out of the 9 criteria according to the DSM-5 for at least 2 weeks without organic cause or symptoms. Diagnostic of other mood or psychotic disorders. The symptoms include sadness or anhedonia. The symptom includes sadness or anhedonia, at least one of which must be present, plus feelings of guilt, energy changes, difficulty concentrating, appetite, activity changes, psychomotor retardation, neurovegetative symptoms, sleeping disturbance, suicidality. Sleeping disturbance or suicidality. Treatment of MDD involves influencing the action of neurotransmitters. Some medication used include SSRI such as sertraline, whereas others block serotonin or norepinephrine reuptake inhibitor. Serotonin and norepinephrine reuptake inhibitors are tricyclic antidepressant. Okay, why it is not anorexia nervosa?
Mhm.
Anorexia nervosa is characterized by intense fear of gaining weight, decreased self-worth related to body weight, and consequent binge and purging behavior, vomiting, laxative, diuretic misuse. Patients with anorexia nervosa often have BMI less than 17 kg per meter square. Physical examination can disclose dry, scaly skin and a fine hair or hair loss as a result of decreased protein stores. Insufficient nutrition and energy loss may lead to anemia. These patients' appetite change and weight loss are more likely caused by MDD as a constellation of depressive symptoms.
Okay.
Okay.
Next. 32 woman comes to physician because 3-month history of diarrhea and rash on her knees. During this time, she also has had a 7-pound weight loss despite normal appetite. She says that 1 to 2 hours after almost every meal, she has severe rumbling and gurgling noises in my belly and diarrhea containing partially undigested food. After the diarrhea begins, she notices that small, itchy, painless red spots appear on her knees. She has not had joint pain. She has not traveled recently. BMI is, wait, what is it? Uh, Low, normal, I guess low. The temperature is fine, pulse is fine, respiration fine, BP bit low. Um, Exam shows mildly pale conjunctiva. There are 4 areas of 5 millimeters red vesiculopapillary lesions over Denise. Reminder of the exam shows no abnormalities. Labs, hemoglobin low. MCV, wait, is that's a bit low. ESR, I don't know. Let me check. And ferritin, I don't know. Wait, let me check. Ferritin female is normal. Iron is normal. And ESR is, where is it? Female is normal too. Test of the occult blood is negative. Which of the following is the mechanism of these clinical findings? Mm, 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 mm.
Ferritin is low, isn't it?
It's normal.
Is normal.
Mm-hmm. Normal low. The no, it's like 10 is like barely there. Normal.
10 is like,
The normal one is 10 to 120.
okay. It is normal.
but you see, it's
So,
kind of
so,
like
y-
on the.
so you were thinking about celiac disease,
I was thinking celiac disease, and what is this one? This one is the.
but in lactase deficiency, there may be bloating, diarrhea.
Which one has the dermatitis herpetiformis?
In the celiac disease. So it is
Uh,
celiac maybe. So you are thinking that this is dermatitis herpetiformis.
I mean, I don't. I'm thinking that's the only thing.
Diarrhea with this kind of rash may be dermatitis herpetiformis.
Or because
Yes, it
then
is.
what else would you have? Okay.
Okay, it's celiac disease. Is a gluten sensitive enteropathy. Is a gluten sensitive enteropathy that is mediated through immune tolerance of the protein gliadin, commonly found in the wheat products. This results in inflammatory infiltration of the proximal bowel, which leads to characteristic intraepithelial lymphocytosis, villus atrophy, crypt hyperplasia, malabsorption, malabsorption of the substance in the proximal small bowel ensues, which presents symptomatically as chronic diarrhea, steatorrhea, nutritional deficiencies. Patients with celiac disease may develop iron deficiency anemia, which may present on lab evaluation with decreased hematocrit and microcytosis. Dermatitis herpetiformis is a vesiculobulbous disorder characterized by small tense vesicles located on the extensor site, elbows, knees, buttocks, which are extremely pruritic. Dermatitis herpetiformis is associated with deposition of IgE along the epidermal basement membrane and is strongly associated with celiac disease. The diagnosis of the celiac disease can be confirmed by detection of the serum anti-tissue transglutaminase antibody or by small bowel biopsy demonstrating villus atrophy along the intraepithelial lymphocytes and crypt hyperplasia.
Can you read D, the lactase deficiency?
Yes. Lactase deficiency presents with abdominal cramping, diarrhea after ingestion of the lactose containing food. Deficiency is Lactose deficiency is not associated with vesiculopapular rash. Okay.
55 woman comes to physician for health maintenance. She has smoked for like 35 years. Previous annual PAPs have shown normal findings. It has been 5 years since her last mammogram. She has never had a screening sigmoidoscopy or a test of the stool for a cord blood. Her sister died of cervical cancer at 50. This patient is at greater risk for death from which of the following cases? Ooh. Hmm. Hmm. I feel like there is a rule for this one, but I forgot. There is a rule. It's like no, it's like the CEO. Is it?
Colon cancer normal screening is age 45, isn't it?
I think so. So
But her
CEO would be
sister died cervical cancer. It is CEO, colorectal,
CEO will be
colorectal,
colorectal,
endometrial, and ovarian.
right?
Yes.
Or C is cervical. I don't know. It's
Is that cervical or
oh, is it colorectal? I think it's colorectal. I don't know.
I don't know. The,
Okay, let's just pick one. I don't know if it's cervical or but it's one of those.
we both are wrong.
We both are wrong. Okay, she smokes. Oh my lord. Ah, whatever. We forgot the whole 35 years of smoking. Oh my goodness. This
Yes,
is
we
just,
ignored the woman with the smoker.
oh, this is just sad. Yeah. This is like the stupidest mistake ever.
The patient's history of smoking puts are at greatest risk for death from lung cancer. Lung cancer is the second common type of cancer and the leading cause of the cancer related death. Tobacco and second-hand smoke exposure are the strongest risk factor. Occupational exposures to asbestos, arsenic, radon, uranium are additional risk factor are as well as a family history of the lung cancer. Lung cancer are classically categorized as either small cell or non-small cell lung cancer. Non-small cell lung cancer include adenocarcinoma, squamous cell carcinoma, large cell carcinoma. Lung cancer in general may present with cough, hemoptysis, dyspnea, and preventive management involves counseling patients on smoking cessation, consideration of low dose CT screening for patients between the age 55 to 80 who have significant smoking history. Okay,
Can you read all the other answers?
yes, breast cancer is the common cause of cancer related death in women. Risk factors include age, family history of the breast cancer, in first degree relative genetic mutation BRCA, obesity, personal history of the colorectal breast cancer, sorry, personal history of the contralateral breast cancer, prior radiation exposure to the thorax, and tobacco smoke and tobacco use. Tobacco use is more strongly associated with cancer risk. Cervical cancer is a common type of cervical cancer is a common type of cancer in women. Risk factors include infection with HPV strains, 16 and 18, history of sexual partner, tobacco use, immunosuppression, family history of the cervical cancer is the first degree relative lung cancer and more common overall, especially in a patient with a smoking history, and the patient had reassuring annual cervical cancer screening without evidence of disease. And colon cancer incidence has decreased as a result of effective implementation of the screening procedure. Risk factors include age, hereditary disorder, familial adenomatous polyposis, Lynch syndrome, diets high in animal fats, inflammatory bowel disease, tobacco use, and patients should be counseled on screening colonoscopy given her age and tobacco use. And uterine cancer is a common malignancy affecting adult women. Risk factors include increased estrogen exposure, obesity, history of infertility, nulliparity, and chronic exposure to tamoxifen Lynch syndrome, and a positive family history. Okay.
Okay. 4-year-old boy brought to physician 5 minutes after choking on a piece of metal. On arrival, he is coughing frequently but is able to vocalize. He's not cyanotic, pulse is high, breath sounds are loud and sonorous, and on auscultation of the chest. Which of the following is the most appropriate next step in management? Hmm.
Mm,
I don't even know what's M. Lynch maneuver.
Heimlich maneuver is pushing the, like you haven't seen in the movie, like
Mm-mm.
some babies eating something and start choking, start coughing, and then somebody comes into the back and like giving pressure over the abdomen to get the things out of the throat.
Hmm.
Maybe that back those, not just maybe. mm,
I don't know. Okay. Ready?
I think it's Hemlich. Oh no,
Now I'm like, if I never heard that word, it's probably not the answer. Yeah, now I'm
That,
because I'm like
that is
we
a wonderful thought.
yeah, because I'm like we studied everything that needed to be studied. So if you've I've never seen it in a question, never heard it, it's probably not the answer.
Okay,
You know?
you are right. Okay,
Mhm.
I'm reading the explanation. Okay, acute onset difficulty breathing and cough raises suspicion for acute onset difficulty breathing and cough raising suspicion for foreign body aspiration. Foreign body aspiration can cause obstruction of airway, leading to impaired oxygenation and ventilation. Children 1 to 4 years are increased risk of foreign body aspiration as a result of the ability to as a result as a result of ability to stand and mobilize independently, ability to grasp and place small objects into the mouth, an immature swallowing mechanism. Foreign objects may be located anywhere in the airway or the larynx and the bronchi. Children can present with severe respiratory distress cyanosis triad but may have a less severe presentation with present partial airway obstruction presenting with cough, tachypnea, decreased air entry on auscultation or wheezing. Chest X-ray can show hyperinflation of one lung, which is caused by air trapping and partial airway obstruction, in which air is able to pass by inhalation but not exhalation. Foreign bodies are Foreign bodies are typically in the right lung as a result of more vertical anatomic position of the right main bronchus. Management of foreign body aspiration involve flexible or rigid bronchoscopy to remove the object. Object removal is necessary, and retained foreign objects can be complicated by airway inflammation and infection. In this patient with mild symptoms, no emergent airway compromise, no immediate intervention is necessary.
Doesn't make sense. Okay. Uh,
So we will not, as the as the baby, after ingesting something, he's coughing, but he can talk. He is not cyanotic. So it is not like medical emergency.
I guess, but the breath sounds are loud. His pulse is high. So I guess, but that's not considered emergency. Okay. I only got it right because I know all the other ones like they cannot be the back blows. This is what everybody does to the baby. They start when they choke when they start, So I know it's not right, but I even do it. It's just yeah. The chest compressions. That's not for foreign body thing. And the mouth to mouth retuti, that's when people are choking when they have water. So that has nothing to do. And the M leech, I just Google, so I know what you mean. But that I know people do it, but it's not supposed to do it. You're not supposed to do it. So that's how I knew it was E, but doesn't make sense because the baby has is a metal. Oh, it's a piece of meat. Okay, I thought it was metal. Okay, never mind, never mind. It's meat. I thought it was metal. So I was like, how can you just leave the metal in the baby? But okay, it's meat, meat. Okay.
You can
Oh.
leave the metal in the body too.
No, but I thought the metal can cause the
No, no, this metal, in it, the metal, if the metal goes to the esophagus, then it like the foreign body aspiration, like taking coins or like
Mhm.
taking button batteries. If it goes to the stomach, then it easily pass out through the rectum.
If it goes to the stomach, then it's easy. So if it's already in the stomach, you don't do anything.
No, we just what we need to do is to do the uh, X-ray, like to see that your ingested product is coming or not. and you can use the lactulose like for bowel to move.
Okay. Got it. 72 woman comes to physician because the physician office was notified of one of the patient's lapsed prescription refills 1 month ago. She has 22-year history of hypertension, 10-year history of arthritis, 8-year history of congestive heart failure. The medication lisinopril, carvedil, furosemide, acetaminophen. The dosage schedule of some of them, this medication required that she take them several times a day. She lives alone and has no relatives near. She appears alert and in no distress. She's dressed appropriately and maintains eye contact. Vital signs are normal. Exam shows mild osteoarthritic changes in, yeah. The remainder of the exam is fine. Assessment of which of the following will be most effective in determining this patient's ability to manage her medication. Wait. What in which of the following will most effective determine this space? So what can show if she can
Manage
manage her
her
medication?
medications most effective
Or determine this maybe. What can show that she cannot manage it? Okay, I don't understand the question. Ability, home environment, gait and balance. Huh? Um, I don't know. Ready?
yes. Okay. In order for elderly adults to remain independent, in order for adults to remain independent in their homes, they must be performed instrumental activities of the daily living. Examples of instrumental activities of the daily living include doing instrumental activities of the daily living. Examples of the instrumental activities of the daily living include doing laundry, housework, shopping, preparing meals, taking medication, managing money, and driving. These are more advanced skills and require higher cognitive abilities than do the basic activities of daily living, such as bathing, dressing, and feeding. In this case of this physician's examination thus far suggests that the patient can adequately attend to her basic activities of the daily living. For example, she is dressed appropriately. However, there is not yet evidence to support that this patient can adequately attend to her instrumental activities of the daily living. Determining whether the patient possesses the skills necessary to refill and correctly take her medication is critical in ensuring her compliance with her medications. Okay.
Okay. Next. 77 men brought to office by daughter because of a 1 month history of progressive difficulty with memory. The patient moved to the US from a small island in Micronesia 3 months ago to live with daughter after the wife died. His daughter says that his memory was excellent 3 months ago, but that it has declined noticeably during the past month. The patient has no serious history of illness, no medication, vital signs normal, physical exam normal, mental status exam. He answers simple questions slowly but appropriately. He defers to his daughter to answer more complicated questions. He has a flat mood and affect. He recalls zero of three objects. Which of the following is the diagnosis?
He recalls zero. Is it vascular dementia or is it dementia Alzheimer type?
Um, I I didn't choose any of those. I because vascular dementia, he doesn't. I don't see anything about like blood pressure,
Gradual decline,
gradual decline.
like
Maybe.
1 month history of progressive difficulty with memory. Then the patient moved on.
And then Alzheimer is usually like you forget like stuff, but it doesn't say he forgets.
He has many, like he recalls 0 out of 3 objects after five
Okay, no.
minutes.
But usually like you get lost in the neighborhood, you
I think
forget the
that it
name.
is pseudo dementia. He is
Ready?
sad, maybe.
Mhm. Ready?
Okay.
No.
Yes. I don't know why I have right. What you have picked.
It's pseudo dementia because the wife died 3 months ago,
Okay.
and then this thing started 1 month ago.
He's sad.
Yeah.
Everybody is sad
No.
along with me. Okay, this patient, this patient who has experienced a recent loss and who has recently immigrated from his home country is likely experiencing pseudodementia. Pseudodementia describes the cognitive deficits associated with MDD in elderly patients. Symptoms of major depressive disorder include depressed mood, diminished interest or pleasure in usual activities, decreased appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feelings of guilt or worthlessness, decreased concentration or cognitive ability, or suicidal ideation. Pseudodementia often represents with relatively rapid onset in comparison to dementia. It can also distinguishable from dementia by poor concentration and effort on exam, apathy, and preponderance of mood symptoms rather than neurologic symptoms or absence of findings suggestive of dementia such as word finding difficulty, dyspraxia, worsening of cognition at night. Pseudodementia typically responds well to treatment antidepressant including SSRI. An event or circumstances that is triggered depression should be investigated in the history. Okay.
Next, 35 men. 35 women with hypertension comes to physician because of moderate right-sided chest pain and cough productive of blood that began 2 hours ago. During this time, she also had mild pain and swelling in her right calf. Medication, thiazide, and oral OCP. Smokes for 15 years. How is she taking OCPs and smokes? She is mild respiratory distress. Temperature is fine. Pulse is high. Regular respiration high. BP high. Pulse oximetry oxygen 92. Cardiopulmonary high, normal. Exam of the right calf shows warm edema, tenderness to palpation. Most appropriate next step.
Is it like OCP, DVT, pulmonary embolism?
Probably
Okay.
ready. Pimp, pip, pip, you got it right.
This patient presents with signs and symptoms of chest pain, hemoptysis, signs of DVT, unilateral cuff swelling, tachycardia, and then this constellation is suspicious for pulmonary embolism. Pulmonary thromboembolism is a common disorder caused by occlusion of the pulmonary artery and impaired blood flow to a segment of lung. Risk factors include immobility, presence of deep vein thrombosis, obesity, recent surgery, pregnancy, use of OCP, smoking, trauma, fracture of the long bones, inherited thrombophilia, pulmonary embolism presence with acute chest pain, shortness of breath, hypoxia. Pulmonary emboli are often undetectable on chest X-ray, but large emboli with infarction can be seen on chest X-ray by secondary signs such as wedge-shaped area of infarction via Westermarck sign or unilateral oligoma. The next is pulmonary CT angiography. Okay, next.
Yeah. I'm still mad about that question about the cancer, the lung cancer. Anyway, 42 woman comes to physician because 10-month history of intermittent diffuse abdominal pain. 10 months. The pain has occurred more frequently during the past month and is not associated with any other symptoms or changes in stool color. She has not had diarrhea or loose stool during the past month. Um, she has not noticed any precipitating factor, but knows that she has 4 children and is always under stress. 10-year history of constipation and often does not have a bowel movement for 4 or 5 days. She has no history of serious illness, no medication. Last year, she was evaluated for similar symptoms. Colonoscopy and CT scan of the abdomen and pelvis were fine. Exam today shows tenderness over the left lower abdomen with palpable fullness in the in the in the lower left quadrant. What is the most appropriate next step in diagnosis? Intermittent diffuse abdominal pain.
10-hour history of constipation. 10-year.
She has not had diarrhea or the stool. Uh, she is not noticed any blah blah.
Colonoscopy, no abnormality.
Measurement of serum anticoagulation.
No abnormality.
Second test, biopsy of the small bowel. Is it? It looks like IBS, right? But then she has the thing that's palpable in the left lower quadrant.
Sorry,
So, but then she has the palpable fullness in the left upper quadrant.
palpable
So,
fullness.
so that, but I still think it's IBS. Never mind.
IBS.
Ready? Hmm.
In IBS, no. Okay.
So, no, is it no further thing at this
Why
time? I don't.
psychiatric? Okay.
Because
Maybe.
I thought it was IBS, so it's like no,
No
it's
further
IBS
evaluation.
for the evaluation. Never mind. I diagnosed right, but
But you choose wrong answer. I
yeah.
was in the dilemma, but I choose the right.
Okay.
Okay. Irritable bowel syndrome is a functional gastrointestinal disorder characterized by the presence of intermittent, often cramping abdominal pain and is relieved by bowel movements and altered bowel habits, including diarrhea, constipation, alternating episodes, and alternating episodes of diarrhea and constipation. Hmm. Patients often patients often report a history of significant stress may present with stress-associated functional disorders such as fibromyalgia, stress-associated fibromyalgia, chronic fatigue syndrome, IBS lacks characteristic alarm symptoms such as onset after age of 50, bloody diarrhea, weight loss, such as bloody diarrhea, weight loss, such as bloody diarrhea, weight loss, nocturnal diarrhea, which should alert the clinician, to alternate diagnosis. Extensive diagnostic testing is not Extensive diagnostic testing is not indicated for patients with signs and symptoms of a consistent. Extensive diagnostic testing is not indicated. Uh, Sorry, extensive diagnostic testing is not indicated for patients with signs and symptoms of outpatient with IBS. Most patients experience an improvement in their symptoms with reassurance, exercise, and dietary modification. Patients with severe symptoms may benefit from pharmacotherapy and directed at alleviating symptoms of constipation or diarrhea. Okay.
32 man comes to physician for routine eval in late winter. He has a history of allergic rhinitis every spring and routinely takes diphenhydramine 2 to 3 times daily when his symptoms begin. His symptoms have been more severe during the past 2 years. He also has had sinusitis during this time, requiring prolonged use of antibiotics. He is otherwise healthy in all the medication. Exam shows no abnormalities. Which of the following is the most appropriate recommendation to prevent a recurrence of his allergic symptoms this spring? Hmm, hmm. Ready?
Yes.
Oh, I see that one coming.
Okay. Allergic rhinitis. Allergic rhinitis is characterized by IgE-mediated type 1 hypersensitivity of the nasal mucosa. Patients commonly experience Patients commonly experience nasal or sinus congestion, rhinorrhea, sneezing, nasal pruritus, conjunctivitis, and tearing. Common inciting allergens include plant pollens, animal dander, dust, mold, whose presence may be seasonally dependent. Patients with allergic rhinitis may display signs of atopic disease process such as asthma or eczema. First-line treatment with inhaled nasal corticosteroid is fluticasone. Other options include inhaled leukocyte receptor antagonists or oral antihistamines. Second-generation antihistamines such as cetirizine may be preferable for many patients because of their reduced central nervous system effects such as somnolence and removal or avoidance of the offending allergen is essential to prevent further exacerbations or and improve symptoms, although this may be impractical for patients with seasonal allergies. Okay,
Unit A.
yes. minimizing outdoor activities will have a detrimental Minimizing outdoor activities will have a detrimental impact on the patient's quality of the life and is not necessary Pharmacotherapy usually provides sufficient elevation of the symptoms for patients to continue with normal activities.
Okay. 57 woman comes to physician for follow-up. She was diagnosed with primary hypothyroidism 8 weeks ago. She's currently asymptomatic. Only medication is levothyroxine. Vital signs normal. Exam is fine. Serum studies show TSH of thyroid stimulated hormone 9.5. Let me check if this is high. Which of the following is the most appropriate next step in pharmacotherapy? Ready?
Yes. Okay. Primary hypothyroidism is characterized by serologically by an increased concentration of the TSH and a decreased T4 caused by decreased production of the thyroid hormone by the thyroid gland. Patients with hypothyroidism should be treated with levothyroxine regardless of the presence or absence of the symptoms, as this patient increased TSH suggests that her physiologic demand for thyroid hormones is being unmet. This patient's increased concentration of the TSH suggests that her dose of levothyroxine is inadequate. This patient's levothyroxine need increased and will need to be titrated until the serum concentration TSH returns to within the reference range 0.5 to 5. Okay.
Okay. Yeah. 68 men comes to physician because 1 month history of increasing severe pain in his legs. He describes the pain as an ache that radiates to both calves. Okay, the pain becomes increasingly severe when he walks more than 3 blocks and results with rest. He has 8 year history of low back pain after a fall from a ladder. Medication ibuprofen, smokes, 45 year, he drinks a lot. Temperature is fine, pulse is fine, respiration fine. BP, just a bit high, fine. Exam shows mild edema of the lower extremity. There is more effusion of both knees. Small effusion over both knees, but no redness or tenderness to palpation. Shins are cold to touch. The shin, okay. Cross straight leg raising test is negative, and deep tendon reflexes are fine. Pedal pulses are uh, 1 plus and equal bilateral. Capillary refill time is 3 seconds in both feet. Most appropriate next step in diagnosis. Ready?
Determination of the ankle brachial index. Determination of the ankle brachial index is the next appropriate step in the diagnosis for patients with exertional leg pain that improves with rest. His symptoms are most consistent with claudication from the peripheral vascular disease. The AVI is a non-invasive means for assessing peripheral vascular disease and can be performed in the clinic. It is commonly calculated by dividing the systolic blood pressure in the lower extremity at the ankle by the systolic blood pressure in the arm at the level of the brachial artery. A ratio less than zero point 0.9 indicates the presence of occlusion of the vascular disease. When the ratio is zero point 0.9 to 1.3 suggests of normal arteries, the AVI an AVI above 1.3 is likely indicates the presence of calcified vessels and also necessitates further evaluation of the vascular disease. Further evaluation may include the duplex ultrasonography and CT angiography. All patients, all patients with claudications, all patients with claudication and confirmed PVD should be started on a statin or antiplatelet therapy. Exercise program should be effective in improving exercise tolerance and increasing neovascularization and collateral flow, diminishing symptoms. Okay, you want me to read the other options?
No, that's fine. 35 women who has
In
been,
this question, what is the striking point, the PVD?
what do you, what do you mean?
The shins are cool to touch. Like, oh, what are the key points have you found to choose the
Yeah,
AVPI, peripheral vascular disease?
yeah, what you just said, the shins are cool to touch. Capillary refill is normally supposed to be less than 2. That's 3. And then the fact that the pain, the thing of the pain, he walks, and then when he stops, he works, and that's when there is pain. And when he calms
Simply.
down, the pain goes away.
Yes, yes.
And then he smokes. I guess that's not really, but yeah, I guess that would be something too.
Sometimes I lost somewhere. I don't know why.
Mm,
Okay.
like, okay.
Sometimes I'll
When
fall lost in the ocean. In
in
some
the
in question reading.
in the ocean, 35 women who has been a patient for several years comes to the office because a pregnancy test done at home was positive. Pregnancy is confirmed by physical exam. During the past 5 months, she had 2 visits to the ED for traumatic injuries, each of which she attributed to her unconsciousness. She is married, has 4 children. Reluctantly, she reports concern about her personal safety and with great embarrassment confesses that the ED visits were precipitated by her husband hitting and pushing her. She says that she's afraid he will hurt her if she leaves him, if if he finds out she's pregnant again. He lost his job nearly 1 year ago. She says that he's abusive only when he has been drinking. She therefore asked to be referred to someone who can terminate her pregnancy. Which of the following is the most accurate statement concerning the patient's situation? Hmm, that's a tricky question.
Oh my gosh.
I don't know. Ready?
Yes.
Okay.
Okay. Okay. Domestic abuse or intimate partner violence may involve episodes of verbal, sexual, financial, emotional, and or physical abuse. Risk factors of intimate partner violence are a combination of interacting individuals, relationship, community, and societal factors. Examples of risk factors for victims include female sex alcohol use, drug use, unemployment, poverty, history of depression or mental illness, and relationship characterized by dominance and control of excessive jealousy, risk factor for preparator perpetrators include exposure to childhood relationship characterized by dominance and control or excessive jealousy. Risk factor for perpetrators include exposure to childhood violence, recent
Mm.
jobs, or instability, substance use. It has been shown that IPV often increases or begins during pregnancy, especially unintended pregnancies. IPV, intimate partner violence, is often difficult to diagnose as a result of patients often concealing abusive relationship. Signs may be subtle or present. Inconsistent explanation of the injury, delay in the seeking treatment, or frequent emergency department visits increase the suspicion of IPV. Okay.
18-month-old girl brought to physician by mouth for routine 18 months. She was born at 32 weeks by C-section because of maternal preeclampsia. APGAR score 5.6. She was in the NICU for 2 days because of fetal lung immaturity. She progressed well and was discharged 1 week of age. She was exclusively breastfed until 6 months when puree foods were added to her diet. She was weaned off breast milk at 14 months. At that time, soft food and whole milk, which she tolerates, were added to the diet. No medication to result of CBC and measurement of blood lead concentration at age 1 year with normal. She appears healthy. She's 25 percentile for length, 5 percentile for so skinny, and I guess more head. 25 percentile for head circumference. Vital signs normal. Exam shows no abnormality. Screening of which of the following deficiencies is most appropriate at this time? Ah, hate those. Um, Soft foods and whole milk. Hmm, I don't know. Uh, uh, vitamin D or iron. Vitamin D or iron. Maybe iron. Uh, okay, I'm pretty sure I'm wrong. Ready?
Yes,
Yes, pretty sure I'm wrong on that. Ah, no, it was iron. Okay.
iron is potentially deficient in this patient. Premature infants are increased risk of iron deficiency. That infants born at term in utero in utero fetus begin to develop iron stores in the last trimester of the gestation. So premature birth reduce the time available for children to develop iron stores. Additionally, preterm infants who have spent time on the neonatal NICU unit are greater risk for iron depletion from frequent blood draws, uh, which reduce their already sufficient iron store. In this patient, iron store TP usually become insufficient within 4 months of without proper supplementation. So all patients should be screened for iron deficiency. Furthermore, breast milk contains little iron, so premature infants who are exclusively breastfed are at even higher risk supplementation. for children who are deficient with oral iron. Why not vitamin D? Vitamin D deficiency is uncommon as infants who are exclusively breastfed receive vitamin D supplement. From where?
Mm?
Like they told us that vitamin D deficiency is uncommon as most infants who are exclusively breastfed receive vitamin D supplement.
I guess from the milk, the mom breast milk has vitamin D.
Okay,
Okay. And folic acid and vitamin B12 also from the mom breast milk. Okay. Um, you want to continue or you want to stop here?
okay, we can stop here.
Okay. I
Okay,
will see you tomorrow.
okay.